Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Okay, everyone, welcome back. We are excited about today's episode. We actually started it before we were recording because we were trying to come up with what we're actually covering today. And the reason this is confusing is because we were differentiating between heartburn, functional heartburn, dyspepsia, Gerd. What the heck is the difference? What are we even talking about? So we want to get into that. And then we also want to talk about ways to support our patients with all of the above. So who has some thoughts?
Okay, I have some thoughts. The conversation that we were just having is one of us was like, well, isn't it always GERD? And I was like, no, technically it's always functional dyspepsia until we have an endoscopy that tells us there's actually esophagitis there or gastritis there. So a lot of us are just having a patient come in and their patient has quote unquote heartburn. And on our ICD-10 choices, we're saying GERD.
What if they don't have heartburn, but they're refluxing? Stuff's coming
They
up.
usually say heartburn,
No,
or they
I
say
totally have
like
patients that get like a taste in the mouth, stuff's coming up, but there is
Yeah.
What ICD-10 code do you use?
Oh man.
Because I usually use GERD.
Yeah, I do too. Anything refluxy, I'm
Yeah.
using Gerd.
yeah.
I think technically...
But I haven't done an endoscopy.
No, please don't do an endoscopy. Please.
It's not in my scope.
That is not your medicine. Technically, it actually is in your scope.
I thought it was removed now.
Please don't
Oh.
do endoscopy.
But please don't do an endoscopy.
Okay, all right, fine.
I mean, I guess Dr. Kapadia, you could do an
I
endoscopy.
have no interest
send
or
them to you.
desire for those job openings that I receive offers for in rural communities where I would be doing surgeries. No one wants that.
Nobody wants that. So I was listening to this phenomenal, one of my other favorite podcasts is the Doctor Journal Club podcast that Joshua Goldenberg and Adam Sandowski put out, which, but guys, if you haven't listened to it, I'm
Terrific.
going to plug it. It's really good. But they had an entire really good episode on this paper that was looking at using turmeric for dyspepsia, for functional dyspepsia.
Wow.
And one of the things they talked about is when one of them were running a study through HealthGot, which is the institute associated with the National College of Natural Medicine, they actually had a hard time recruiting for that study, mainly because nobody gets diagnoses of functional dyspepsia.
Right.
They
good
get diagnoses of GERD.
Yeah.
And this paper was specifically looking at functional dyspepsia, which presents the exact same way, plus or minus a diagnosis.
Okay, so here's my question. How do you dose the turmeric? Because if we're going for the upper GI, you're not going to use a capsule, are you?
I think they were using capsules.
Wow, and it still worked.
And it's actually, it did have and it did have efficacy.
Cool. What were they thinking is the mechanism there?
Anti-inflammatory.
Inflammation?
I think that was the mechanism. It's
Cool.
been a second since I've listened to the episode. I will personally say that I learn better with auditory learning than I do with reading learning. That's just how I learn. And so that episode was so useful because they're talking to me while I'm driving in the car. So I highly recommend it. But okay, the first question we have is, what are we covering?
Yep.
Are we covering dyspepsia?
What is
Are we
this
covering
episode?
GERD? Are we covering reflux? And does it matter?
Well, so do you treat them differently?
I probably will be more aggressive if I know they have esophagitis or gastritis. How about you?
Right. I mean, if they had an endoscopy and they had findings, then
scary
we would
stuff
treat,
like Barrett's.
or even just, more significant changes than what we're just assuming.
So
before
have you
they have
seen an endoscopy that doesn't have gastritis?
Yes.
But it's super
they're
common. I mean, it's
so
super common. But yes, occasionally they don't have gastritis.
Very rare.
I have definitely seen EGDs that do not have gastritis.
Okay.
Or esophagitis.
Okay, so it does exist.
It does exist. Yes.
Some people in this country do not have gastritis.
But who are we sending for endoscopies,
yeah, exactly.
right?
Yeah, we're selecting.
Yeah, I mean that is very, very true. There, like where we do screening colonoscopies, we do not do screening endoscopies.
Please don't add it to the list of
screening.
Preventative screening.
Yeah.
Right.
So I mean, I guess our first question is the only difference that I can come up with is I'm significantly more aggressive with treatment. I'm also in that more aggressive with treatment, I will go a little bit more readily to pharmaceuticals.
Mm-hmm.
Right. Totally. If they have an ulcer, obviously.
Yeah. So ulcer, like cell changes.
Yeah. Pre-neoplastic changes, all of those things need more aggressive treatment.
Personally, even if they're just uncomfortable.
Right.
Like if it's a painful gastritis, really I personally don't, and this might be the thing that gets me canceled in my naturopathic functional medicine community. I do not have hesitation about putting somebody on a 3-month course of a PPI.
Yeah.
I actually find it very helpful.
Yeah, it is really helpful. It's just you have to monitor it. I think where we really get in trouble is like just keep people on it forever because it does work. It totally
in the
works.
Short term.
Yes.
But it has to be short term.
In the short term, it's very effective in the short term.
I actually did a publication during residency on the adverse effects of PPIs. I agree, but this was like 20 years ago. Even then we were recognizing that there's potential complications of usage, and we know even more now. But of course, I agree there's times when we need to use it. The sad part about my research was I found this study that showed increased in IgE food allergies with very short courses of PPIs.
Very like
I'd have to read my publication again.
Yeah, what are the risks besides that of short-term use?
Short-term, most of the studies are on more involved, so community-acquired pneumonia, C. diff, other things like that. But I don't recall like what is there like a short-term use that has not been associated with any problems? Is that 1 month? Is that 2 months? Is it 3 months?
And my question is, has that even been studied?
Right. Because we're looking at more people who have been left on it.
They are so used. I'm sure we have data on short-term.
Do you guys want to know something interesting? There's about a new drug class is about to come out, which is probably going to change everything.
Have you increased your consulting with?
No, well, that's so funny. I did learn about this.
You've got some insider information.
I did learn about this while I was doing a consultation call with one of the people that
one of your conflicts of interest?
With my main conflict of interest. Yeah, isn't it sad that I have conflicts of interest?
Fine.
Yeah.
It's fine.
Okay. It's sad that you have multiple. You have to keep them straight.
I do have multiple. It's true. Wow. Oh, guys, capitalism. I just.
It happens when you're a turdy celeb.
Yeah, and that is a badge I wear with high honor. So apparently there's this drug class that's been utilized, and this does actually fall under the episode. Like I'm not just on a tangent, which I know I have a tendency to go on tangents. There's this drug class that's been utilized in Japan for the last decade, which is working on the potassium ports. So it's a potassium uptake that will change the pH very, very quickly. And I think according to Japanese data, is safer than the PPIs, and it's about to get introduced to the U.S. market.
Great.
So it's like a potassium inhibitor. Very, very, very interesting.
Yeah.
About to change everything that we do pharmacologically in this country with reflux. And I personally am like where I land at PPIs are useful, especially for short durations. They've never been any of the treatment data looking at long-term use was never there. The treatment data initially was for short-term use, and there is efficacy in short-term.
Right.
I usually go 3 months.
So in the medication realm, why would you do that over like famotidine?
Because I think it's stronger.
It is stronger.
Yeah.
Do you start with famotidine and then move up to a PPI?
I generally start with a PPI because and so there's a couple of things that I usually do. A, I start with a PPI, and B, I never only just use pharmaceuticals. I will always use the herbs. The herbs in my clinical experience and also in the research are very effective.
Yeah, the way I explain it to patients is like the PPI is going to stop the damage that's happening. The herbs are actually going to go in and heal. PPI alone, the stomach may be able to heal itself, but the herbs are going to go in and support that process.
And I think that's where I think I landed at the 3-month course, because I think at 3 months, it will heal itself.
Yeah.
You know what I mean? Like time heals all wounds, including gastritis and ulcers.
Yeah.
Yeah, and I mean, I don't go straight to a PPI. If they're having milder symptoms, I think both of you also, you can definitely start with an H2 blocker.
Yeah.
If it's not working, of course.
Does someone want to talk about why histamine blocking helps acid reflux?
Okay.
Who wants to?
So I can tell you that when you're, isn't it the building block for acid?
Well, I feel like we briefly mentioned this in one of the previous podcasts, and
I know we've touched on it.
It might be more of a mechanism that we need to just
dive into,
look into further before we. But I feel like it has multiple mechanisms. We give it for reflux, but we also know that histamines can be irritating for a lot of people.
We give it for MCAS.
Right. So it's sort of like for our patients, at least, sometimes we're hitting two birds with one stone, and so I feel like sometimes it works better than a PPI if they're not, if the acid
really
isn't really there.
Acid reflux as
right,
well.
For some.
Yeah.
It depends on if they're actually having, because the studies, at least when they looked at, is someone having hyperacidity or lower acid or what is going on here, it's not always elevated acid, as we know.
Yep.
If it is, then a PPI will work better, but if it's not, then not necessarily.
Yeah, I see so much histamine stuff, GI stuff in my practice. I usually am starting with famotidine.
Yep.
So I will tell
realm
you,
are we even in?
At this, for a patient to come in and see me, they've probably seen at a minimum 3 other naturopaths and multiple other physicians, right? And what I see in our community, especially, is there is this real big fear, but also this real big dislike for PPIs. I had a patient come in who has seen like literally everybody, and his ex-wife was a naturopath, like literally he has seen everybody, right? And good doctors too. And he came in explaining to me this crazy discomfort. I mean, this dude like does yoga, changes his diet. His diet is impeccable. He follows all of the lifestyle stuff. He never eats at least 4 hours before bed, like everything, right? And I was like, when was your last endoscopy? And he was like 7 years ago. And I was like, this pain is not normal.
Right.
You need an endoscopy, right? And I put him on all the herbs. Like, I see that you're on fire. While we're waiting, let me just start healing stuff up. And I offered him the PPI. He decided, no, I don't. He's married to a naturopath, or his ex was, you know what I mean? He's in our community.
A particular scenario where it would have been the right choice, likely.
So we sent him to get an endoscopy. No, he had Barrett's.
Okay.
Oh.
And so the gastro said, take a PPI. And then he was like, do I take a PPI? And I was like, hell yes, take the PPI. And then
that's
he
the
goes,
indication you have to take it forever.
And then he goes, why did it take so long for somebody to tell me to get an endoscopy and start me on? He was out of pain in 3 days.
But he had an endoscopy previously, but he was not symptomatic at that time.
And he was younger. And
he
just
was had
thinner.
it for other reasons.
No. He was symptomatic.
Okay.
But he wasn't as progressed.
It got worse.
It got significantly worse. And he just kept on trying to treat it. And, that's the thing about our community. Like, there is a time when pharmaceuticals have value.
Yeah, like constipation. Like, I gave a whole talk on that. I think, like, we want to monitor. And I think we can monitor better than, in the conventional world sometimes. Because we can do more follow-up. We can do more thorough follow-up.
Yes.
But they're great tools.
Right.
And they work. And they can give people their life back. They can prevent disease.
Literally, he was like, I was out of pain. I have not had any pain from 3 days after I started.
And it might have prevented the Barrett's.
It could have prevented the Barrett's.
I mean, I don't actually know that, but
well, that's a tricky thing, because it would have been unnecessary before he had Barrett's for him to be taking it regularly
if he wasn't as symptomatic.
Right.
Yeah. So PPIs work.
So PPIs
they really
work.
help. You want to know when and how to give them and monitor. You're not just
and
willy-nilly leaving them on.
And it's not a long-term forever. It is a short-term intervention
unless
that's
it's
effective.
Cancer prevention, and we really need to have them on board. But
So then H2 blockers. What's your thought about longevity with use of H2 blockers?
Well, I think it's risk-benefit again. Obviously, I think most people, if they can get by without a pharmaceutical, they prefer to do so. Not everyone. I mean, if it's helping that much, then the benefit outweighs the risk.
Right.
I took a deep dive into nutrient deficiencies with H2 blockers, and after a couple years, there could be B12, zinc, other micronutrient deficiencies. So you want to monitor all of those if they're going to be on a long-term H2 blocker. Right. But I certainly feel more comfortable if it's working for someone to be on a long-term H2 blocker than a long-term PPI. I haven't seen the data on other comorbidities.
I definitely think they're safer.
Yeah, I think they're safer, and I think there's there's supposed to be a little bit more flexibility with dosing.
Right.
You can dose as needed, whereas a PPI, you're not supposed to do that quite as much. It's supposed to be, more consistent use. So that's beneficial to patients.
Right.
Just pop it as needed. And you can use it in a titration if you're doing herbs and kind of weaning people off as well.
Are you going to talk about the herbs that you use?
For sure. But first, I think what I want to talk about first is forget herbs, forget PPIs. How about lifestyle?
Right.
That. I feel like that's where we should be started.
We should start there.
Okay. other drugs, because there are other things
Yeah,
out
let's
there.
do that. Let's
like
talk about
if
that.
we're just doing the realm of pharmaceuticals, like when are you using cromolyn? Why would you use
When are-
cromolyn?
Okay, so I think I would pull for cromolyn if they're looking like they have a big histamine picture in their GI. If they're having bloating, if they're having reflux, if they're having any systemic mastocytosis symptoms, you know, I think I would think about cromolyn.
And if they obviously if they've been diagnosed with EOE,
Right.
eosinophilic esophagitis, or if their symptoms seem to be food sensitivity related in any way, they often don't know that. So that's hard to kind of tease apart because it could be things they're eating all the time.
How often are you seeing GIs pick up EOE?
Frequently.
They've been picking it up.
I'm seeing an uptick of it.
Yeah.
Recently.
I think there's an awareness probably because there's a new drug coming out.
Oh.
Is there?
I mean, here's what
How do you know all this up and coming?
Because of Medscape. I don't know if you guys get Medscape. I don't know if you guys get Medscape articles, but all of a sudden when Medscape starts, and I put my interest is gastro, when Medscape starts flooding my inbox with one particular condition, there's a drug coming. Yep.
Totally.
Yep.
Oh my gosh,
there
that's
is,
crazy.
and I also think I was in a meeting a little while ago, and I was with two gastroenterologists, and they were working on the new, what's it called when like the expert guidelines.
Consensus statement?
The consensus statement about guidelines for EOE. Okay. So I think there's that pipeline is starting. So there's an awareness in the conventional gastro world.
I wonder what it's going to do. I wonder what it's going to work on, you know, outside of the cromolyn and the...
I mean, based on what I learned about the new potassium drug, it's going to change everything.
Yeah.
Yeah.
So I am a little different in the cromolyn use. I am starting it sooner. I'm giving it more frequently, and I'm seeing it help a lot with symptoms.
Isn't there a backlog of it? Can you not get it?
Well, it's been like that on and off for years, I feel
It has?
Right now, like the commercial product is really hard to get, and it's like the waste and stuff is a whole thing to talk about with that. But if their heartburn is responding to cromolyn, that gives us a whole avenue of things to be able to treat, and it's like pretty low stakes.
Right.
Yeah, it's true. So the drug that you're talking about is cromolyn sodium, and basically it's a mast cell stabilizer that's localized to the GI tract. It's not a systemic.
It's topical.
Yes, it's a topical, yes.
You can put it in your eyes. You can put it up your nose. You can put it on vaginal tissues. You know, you can use it in the gut. Yeah. So it's stabilizing mast cells that exist everywhere, but maybe more reactive in mucous membranes and in our gut.
Yeah.
So it's basically like you dose it before meals. Topical treatment essentially doesn't really get absorbed. And it I tell my patients, it sort of primes the digestive tract to not be so excited about the food that's coming in. So you can tolerate food a little bit better. But I am seeing it really help with things like heartburn. And if they respond to it, then maybe we think about quercetin or some of our herbal mast cell stabilizers.
And then, you know, the most common side effect that I see with it is headaches.
That's random.
Really? I actually see a fair amount of headaches. Maybe like
do you
10,
tell people
12%?
That they might get headaches?
When I am part queuing them, I'm pulling up Hippocrates. When I part queue everybody for any pharmaceutical.
I don't think I've ever had anyone get headaches.
Oh, yeah?
I don't know that I've actually seen that either.
Oh, yeah. I've seen a fair amount. Interesting.
But it's not systemically absorbed.
It does not matter.
Well, I mean
everything is a little
systemically
absorbed.
It somehow can help with systemic
and you know these people all have
though.
some kind of permeability in their upper GI and middle GI. Like,
weird.
They're patients of ours.
Yeah. Even compounded?
I use compounded significantly less unless somebody can't get it.
It's super pricey.
Yeah,
to get to the dosages.
And someone told me recently because the powder clumps and it's hard to like get it in a liquid form. If you want to coat that upper GI, to use a milk frother.
Oh, that makes perfect sense.
They're pretty cheap, online, and it just blends it up.
You just want to hang out at home all day and
froth
your
cromolyn.
I don't know that a lot of people are going
to
be into that.
But... Well, milk frothers are like a pen. Like they're more like a marker.
People think you're just frothing your coffee.
You need a big bag.
Fit right in at the office,
You need to carry it a big bag, but I will, and I mean a lot more people work from home than ever used to.
That's true.
So what other drugs? Calcium carbonate, Tums.
Yeah.
When would we use Tums?
Yeah.
I mean, it's just an easy. If you're getting heartburn, occasionally you might be if they're overeating or this or that. I think it's fine as long as you're not taking it every day forever.
Yeah, it can be really helpful. The pregnancy heartburn, I'm usually because it's either like the progesterone's loosening all your sphincters.
Yeah.
And your gut just slows way down. But it's a huge issue in pregnancy.
Yep.
I start with papaya enzymes and like lifestyle stuff that we'll get to here in a minute. Then move up to regular plant-based enzymes. So shout out to that episode to go check out. And then Tums.
Yeah, and so I do like if I can get management
Yeah.
with using some kind of chewable base, because that's basically what Tums is,
Yep.
I prefer to start there.
Yeah.
But it really depends on longevity of their sickness and acuity.
And that it's acid.
Yes, and that is acid.
If
Yeah.
you're having
And-
alkaline
right.
reflux, that is not going to work.
No, that's going to make it worse.
Yeah.
And if they've already had other things ruled out and you're just trying to figure out something for symptoms,
Yeah.
until
It's cheap,
so
it's
sucralfate too can be used.
Yeah.
as
Oh,
to the
sulfurfate. Yeah,
stomach.
that's a huge one
Yeah.
to talk about.
Yeah.
Do you want to talk about what that does?
I mean, there's not. I would just use it to. It just helps coat the stomach.
It literally just coats the
Yeah.
stomach.
Yeah, I've seen them use it in dogs a lot.
Interesting.
Yeah.
It is so old.
It's
It
so
is
old.
such an old
Right,
drug.
right.
I have a patient who's also very complicated, very, very uncomfortable. Tried all of the things, tried the
Yeah,
PPI.
yeah.
PPI made it worse because it was probably not acid. Yeah. And then he went on like not even like a short course, like 2 weeks to a month course of sulfurfate once a day.
Isn't it
changed his
similar
life.
to DGL? Same concept?
But times 100. It's also similar to
yeah,
Pepto.
well, yeah,
It's also similar to
pharmaceutical.
liquid Pepto, like a bismuth.
Yeah.
Because that's something else that can be useful is a bismuth.
Yeah.
Totally.
Yeah, Pepto is bismuth salicate, but also great at coating the GI.
Yeah.
So, okay. So do you think that closes up our pharmaceutical topic?
I feel like we're gonna
so.
forget some.
Yeah.
There's so many mechanisms that go into this. Like we could do all the mast cell stuff, histamine
Right,
stuff,
right.
leaky gut stuff, because you can have that anywhere in the
Zinc
digestive tract.
carnosine.
That supplements,
Yep,
we're going to
yep.
do that different.
Okay, sorry.
Shh, shh, shh.
I got them confused.
Spoiler alert.
It must be a drug in some country. No.
I don't know. It's a great question.
I think it was
learned
studied
that
in Japan.
DHEA is a drug in Canada.
So is melatonin.
Wow.
So is melatonin. There's another one that's also kind of crazy. Also, in most countries, you can get lactulose over the counter.
Totally.
But it's
I
a
don't
drug
know why
here.
NSAIDs are over the counter. I feel like of all drugs.
That's a really good point.
I
A lot of
mean,
damage
let
with
people
those.
like Cromolyn. That should be one
Yeah.
they're allowed to buy
Yeah.
over the counter.
Totally. Yeah.
Anyway.
You know,
Who's making these decisions?
Yeah,
there was
I
this
don't
great
know.
article I think I told you guys about that woman who lived in Germany. And in Germany, when you get sick, they're basically like, go home, lay in bed, drink tea.
Mm-hmm.
And here you get sick and they're like, where's your antihistamine? Where's your NSAID? Where's your fever reducer?
Block
Where's
everything.
your... Yeah. It's a cultural thing that we
Yeah.
have here.
Yeah, we have to hit it hard.
So now should we move? I think as much as overview of fast drugs we did,
Yeah.
should we-
Right.
let's move into lifestyle.
Okay, great.
Yeah, because I think lifestyle is like, that's where we should be starting.
Yeah.
Yep.
That's
Yeah.
really where we should be starting.
Yep.
So there are some very known triggers that will often trigger reflux.
Diet, you mean?
Diet. Let's do that.
Citrus, tomatoes, chocolate
Spicy,
for some people.
alcohol, peppermint.
Caffeine,
Caffeine.
chocolate.
Yep. So anything that loosens the lower esophageal sphincter. And this I learned is not standard. Like people have their triggers. So it's worth like giving your patients a list and saying, try these out. Because if you can go ahead and eat citrus, terrific. If you can
Right.
eat chocolate,
Yep.
your life will be better, but it's worth
And
knowing.
I will also say that
can't-
people generally know.
Yeah, people
It's
know.
none of this, like when I get reflux,
Yep.
I know that it's the chocolate
Yep.
that I ate at chocolate o'clock
Yep.
that causes my reflux.
Yeah, and there's a threshold, there's a time, like maybe you can have spaghetti, but you can't have spaghetti with the red wine.
Yep.
You can have them separately, but
Also, refined foods. Like refined foods is one of the most common triggers
Totally.
for lots of people. It is a big
For lots
ask
of things.
for lots of things for almost every
For
health
all people.
Yes.
Whether you know it or not.
and for almost all every single chronic health issue that we have, getting rid of the refined and ultra refined, especially foods, is the most important.
yeah,
So, breads, pastas, crackers,
the
cakes,
white stuff.
the white stuff.
Yeah.
That tastes delicious and is highly addictive.
What about carbonated beverages?
Oh yeah, total trigger.
Yeah, I see that
Yep.
too. Even just carbonated water, like we're all addicted to it. It's
Yep.
delicious, whatever, but moderation, because it does like you're shoving gas into the stomach. It has to come out,
Yeah.
and it has to loosen that
It's a
lower
good way to think
esophageal
about it.
sphincter.
Every time you take a sip of your
Yeah.
sparkling water.
I mean, really, it's not leaving any other direction,
Right.
so
Yep.
it has to come out through the tube that's trying its
Yep.
best to close.
Up or down.
Up or down. It's got to go one way.
We're
Yep, that
just
totally.
a tube. We're just a tube.
I mean, unless it gets stuck in the middle,
Yeah.
and then that's a whole different other kind of
Yeah.
hell.
Yeah.
The bloating hell is stuck in the middle.
We've all been there.
And so I would say carbonated just on its own, and
Yep.
also carbonated with high sugar, so the
Yeah,
sodas.
big time. Yeah. Ugh,
Yeah.
rough.
then not eating before bed.
Okay, so that's, I think,
Right.
the most important.
Yeah.
I think the most important is just the anatomical. You want to cut off, you want to make sure your digestion is well out of the stomach by the time you're not done digesting
Laying down.
Yeah, use
before you lay
gravity
down.
to your advantage.
Yep.
Help it digest your food. Don't get sideways and put that giant stomach full of stuff.
Yep.
Don't put that pressure on the sphincter because it
Right.
will loosen.
Right.
And you're going to feel miserable.
And then, so cutting off food, I think 4 hours before you go to bed.
I have to mention my,
Uh-huh.
I was several years ago, my husband would make this crazy smoothie. Before, I was like, are you trained to be a sumo wrestler? Like, this,
What was in the smoothie?
It's like a 2,000 calorie smoothie. Like after dinner, I'm like, what are you doing? I know you exercise a lot.
Was it a
Why?
smoothie
Can
or a
you
milkshake?
please not do it
You
right before
exercise
bed?
a lot. Yeah.
Well, he would go surfing and then he'd be hungry. But I'm like, can you not do it right before
Yeah.
bed?
Did it affect him? Was he one of the people who were
Probably-
symptomatic?
No, but it bothered
Yeah.
me still.
But over time, you are looking out for his anatomy.
Yeah, so I was
Yeah.
like, this is not a good way to live.
No. I feel like I'm getting heartburn just thinking about that. So,
Anyway, I had to
I'm just going to
mention
enjoy
it.
my tea as you talk about your heartburn.
Yeah,
To give me
right.
more heartburn.
yeah.
All right, so don't eat
that
before
brings
bed.
me to eating or drinking too many liquids with your meals.
Mhm.
Right, which
Yeah, talk about that.
Diluting your
Yeah.
stomach acid, diluting your enzymes, all the great stuff that
Yeah.
helps your stomach empty its contents and
Yeah.
digest. If you dilute it, it's going to come right back up because it can't break it down.
That is a naturopathic principle that I always struggle with. I very much struggle not to
I think
drink
Ayurveda
with
too,
food.
or I don't know.
Yeah.
I never drink with my meals.
I
I don't
don't
know.
either.
Yeah.
I do.
Yeah.
Huh.
I struggle with that. Chinese medicine, I don't think I think
Maybe hot liquids are fine. Hot tea.
Yeah, you don't want to cool the burner.
Yeah, my resident was in with me, rotating through with me, and she was so sweet. She like replaced my, I'm always drinking water with patients, and so she replaced my water, and I took a sip, and I was like, cold? Who drinks cold water? I was like,
What
this
is
is
this?
shocking to my warm GI
Right
tract.
against the wall.
I was like, you're Chinese medicine trained, and she was like, I know, I couldn't get the hot.
Oh.
So also, I think cold water does make it makes me
It
more
slows
uncomfortable.
digestion.
Yeah.
So if your reflux is at all related to slow digestion, and migrating motor complex,
Yeah.
I think it's worth enhancing the function of that, which is meal spacing.
Yep.
Even during the day before
Yeah.
bed for sure, but
Right.
just making sure small intestine's emptying, cleaning itself
Yeah.
out appropriately.
And then quantity of food. Like, it's hard
Yeah.
not
For
to
sure.
overeat sometimes
Yep.
if the food's really delicious, but that certainly will contribute is the
Yep.
quantity.
yeah.
And then the opposite of that is also frequency of eating,
Right,
because
right.
if you're eating too frequently, you're turning off the
Right.
migrating motor complex.
Yep.
Yeah, so I think that the rule in many Asian cultures is, which is difficult for us as Americans or Westerners in general, is eat until you're 80% full.
Right.
Yeah.
And that's kind of a hard feedback mechanism to get
Yeah.
into, but you don't just want to be eating forever. You want to eat until you're 80% full.
Yep.
Yeah.
Hard sell around here.
Yeah, especially if you're eating something really delicious.
Yeah.
Totally.
Yeah, I know. Or sweet. Yeah.
Oh, like that cake you brought over that I had to give back.
By the
I
way,
was certainly
I
more
got
than
it.
80% full.
vegan
It's still
nut,
bingeable, Alana. It's still
vegan
bingeable.
nut cheesecake sweetened with maple syrup.
Had
It
to
was
give
raw,
it back.
wasn't it?
Had to give it back.
It was a raw, it was a raw
I
cheesecake.
love a good raw
I
cheesecake.
make fun of me for bringing back my vegan cheesecake, but one of my best friends made this gluten-free
Oh, yeah.
tiramisu which is soaked in espresso,
It
and she
sounds
soaked
amazing.
it in
Yum.
decaf espresso, but
Oh.
I could not control myself, and I'm eating it at 9 at night, and then at 12:30 I'm like jumping off the walls. I had to return it to her house.
It's not
I cannot
safe.
be trusted
It's
with
not
this
safe.
gluten-free
Yeah.
tiramisu, the best
That
dessert.
sounds amazing.
It was amazing.
Maybe we can make it again. And just eat it once and then leave it with someone who has
I think we have to make it for a big
self-control.
gathering.
That's
It
a
has
good
to be
idea.
a big gathering so it can go away. I want to enjoy it and
I
not
have
have
an
it stay.
unusual number of friends who have like desserts that just stay in there.
Yeah,
And I'm like, how is
I'm
this?
kinda one of
How
those
is this still
people.
there? Okay, so we can drop it off
I'm
here.
more of a savory dairy person.
I will ice cream.
I do that too. If I buy cheese, it's gone in
love
like
cheese.
a block of cheese.
Your dopamine.
It's gone
Yeah.
in like 2 days.
Is that what that is?
It's dopamine, yeah.
Love dopamine.
We-
Who
Um,
doesn't like dopamine?
No, it's amazing. Dopamine's
Yeah.
the best. Yeah.
Cheese.
Yeah. Sugar. Okay. Any other big lifestyle?
Propping up the head of your bed.
Oh, yes. That's really
That can be really
useful.
helpful.
Yep. And there's a couple of different ways to do that. One is to sleep with a couple of pillows. That's
Yep.
not as comfortable. One is
Yeah.
to buy a wedge.
Yep.
And then the other one is actually to lift the head of your bed.
Yep.
Some blocks.
With some blocks, so you don't necessarily feel that you're that way, but you still are.
Kind of challenging to do
Yeah,
with the bed
but
frame
worth
and such.
it. Like
but
some people, especially in pregnancy, it can really help.
how did
Just-
you lift the whole? It wasn't hard.
I had a wedge.
Okay.
Yeah.
Is the wedge uncomfortable? I've never had one.
I mean, pregnancy's uncomfortable.
Yeah, that's true.
the whole thing's uncomfortable.
Yeah.
So,
Yeah.
what about body work? Does that count as lifestyle?
I think it's worth talking about. This is the time to talk about it.
Yeah. So I think if people have intra-abdominal tension,
Yeah.
correcting that can really help.
Yeah.
Just move the stomach through, move things down.
Oh, and exercise.
Yeah.
Oh, exercise.
Yeah, we didn't
I
even
think
mention.
abdominal movement at
Yeah.
all, whether someone's doing it to you or
Right,
you're
right.
doing spinal twists, riding your bike, like getting things moving,
Yeah.
that stagnation piece isn't helping anyone.
Yeah.
Okay,
Yeah.
great.
I think those are the main lifestyle things.
Yeah.
I think
Yeah.
that we'll do a whole nother episode all about the supplements. Yeah.
Heel drops.
Heel drops are interesting. So
Yeah.
I do use this a lot, but I
Yep.
use it more with like a hiatal hernia syndrome.
Totally.
And basically what you do is you drink 8 to 12 ounces of warm water
Mm-hmm.
in the morning, first thing in the morning, empty stomach, and then you stand on your tippy toes and you drop heavy on your heels. Stand on your tippy toes, drop to your heels,
Mm-hmm.
and you repeat that 10 times, and you can do that multiple times. Will it help? Sometimes.
Yeah. I'd say sometimes, like
Yeah.
10 to 20% for
Yeah.
people who actually have that.
Yeah.
And are trying to tug the stomach down, but
I
feel like we learned it, and I was like, cool.
Yeah.
And sometimes.
Sometimes. It's a good tool that you have for patients to like help themselves.
Yeah. Well, I'm really excited in our part 2 to dive into herbs
Yes.
because we
Yeah.
we have so many
Should we
things.
summarize part 1?
Yeah.
Yes.
So we talked about this whole sort of conglomerate of GERD, reflux, heartburn, functional dyspepsia. We talked about pharmaceuticals. PPIs have a role for sure. Just don't put them on the list and never look at it again.
Yep.
H2 blockers, sucralfate, cromolyn, MCAS, histamine meds.
Yep.
I'm sure there's
Over the
more.
counters.
Tums, any like a base sort
Yeah.
of implementation. And then we talked about lifestyle changes, spacing your meals, not eating right before bed, exercise, abdominal movement and massage.
Avoiding the crap, the carbonated,
Right.
the coffee,
All
the
the diet
chocolate.
stuff.
Yeah.
all the good stuff.
Support your
Try not
migrating
to
motor complex.
overeat and eat like a 2,000 calorie smoothie right before bed. All of
Unless
those
you're trying
types
to
of
become a super
interventions.
wrestler.
That's about it.
Okay, yeah, that was a great
All right.
episode.
Awesome. Thanks, everyone.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.